to the epidemiology lecture series. Today, I'm going to discuss about the bias in screening. In the previous lecture, I promise you that in this lecture, I'm going to discuss volunteer bias, lead time bias, and length bias. So let's discuss one by one. To discuss volunteer bias, I have two populations, screen population and non-screen population. If people are volunteering for the screening program, what can you say about those people who are volunteered for the specific screening program? If somebody is volunteering for health program, these are the people who are more careful about their health. They are the people who are following the medical advices carefully, who are taking the drugs for specific diseases, who are doing regular testing to make sure that their health is good. In practical situation, think about a practical situation. We go to a village and we apply screening process. If the process is not random, what will happen? For the screen population, those who are more careful about their health will participate for the screening program. If the volunteers are high in the screen population compared to non-screen population, most probably their mortality will be low, morbidity will be low, survival will be high. This is not because of the screening program, because we apply screening program to identify disease at an early phase. But this is not because of the screening program, but it is because of the properties of this specific sample. People who are more careful about their health are coming to the screen population, and who are not careful about their health will be high in this population. Because of that, their morbidity and mortality will be high and survival will be low. The next two biases, lead time bias and length bias, are mainly based on this one, that is survival. Let's discuss lead time bias and length bias. Okay, to discuss lead time bias, I have two patients, screen patient and non-screen patient. Assume that both people have same cancer. Both have developed this cancer in year 2001. Assume that this is slowly progressing cancer. And this patient participated for the screening program in 2005. So this is the diagnosis. He was diagnosed in year 2005. Patient was diagnosed in 2009 after developing the complications. By the year 2005, both patients have not developed the complications, but because of the screening program, this person was diagnosed, and both people have died in year 2019. So what is the total survival duration for screen person? 2001 to 2019, approximately 18 years. In non-screen person also, from 2001 to 2019, again approximately 18 years, no difference. But if you analyze this, the period from diagnosis to death, here the total duration is 14 years. Here the total duration is from 2009 to 2019, 10 years. But actually, these two patients, there's no difference. But in analysis, because we don't know the onset time, because of that, we falsely come to a conclusion that this patient has long survival duration, 14 years. This patient has shorter, and we can come to conclusion that this is because of the screening program. We identify this is at an early phase, so the duration is long. But it is not actually due to screening program, but it is due to lead time bias. I hope that you are clear about lead time bias. To minimize lead time bias, we need to include this duration in the analysis. If you can include this onset to diagnose durations in the analysis, we can minimize the lead time bias. I hope that you are clear about lead time bias. So let's discuss what is length bias. Length bias occurs when there are several forms of same disease. Same disease can have rapidly progressive type and slowly progressive type. For example, in a cancer, there might be mild form and severe form. If somebody has mild form, naturally there's high probability to be the prognosis is good. So he may survive for a long time. And if somebody has severe form, he can't survive for a long time. The other thing is, if the disease is mild form, there's prolonged preclinical phase. Prolonged preclinical phase. But here, he has shorter preclinical phase. In the definition, in the first lecture of screening, I hope that you can remember I discussed screening is identifying patients preferably within the preclinical phase. As the preclinical phase is higher, there's high probability to catch this patient by applying screening. But the probability of identifying this patient is less because of shorter preclinical period. Now, when we are analyzing the effectiveness of screening program, somebody might come into conclusion that screening program is effective because of the two forms of disease. The screened population may contain lot of patients with mild form of disease with prolonged preclinical phase, but in non-screened population will consist of this fastidious or severe form of disease. Because of that, the preclinical phase is less. The probability of capture them by screening program is less. We falsely come into conclusion that the screening program is effective because of length bias, not because of the screening program. As epidemiology students who learn screening, you should keep in mind that length bias, volunteer bias and lead time bias are the three main important biases affecting the effectiveness of screening program. I hope that you are clear about volunteer bias, lead time bias and length bias, and think about different other possibilities where you can come into false conclusions that the screening program is effective. Thank you very much for listening.